Myself, DrShruthi, second year PG in KIMS Amalapuram, Andhra Pradesh. My topic of presentation is a clinico-epidemiological study of cutaneous adverse drug reactions in a tertiary care center. Conflicts of interest are nil. Coming to introduction, an adverse drug reaction is an undecided clinical manifestation resulting from administering a particular drug. Cutaneous adverse drug reactions are common, comprising 10 to 30% of the reported adverse drug reactions. There is a spectrum of cutaneous adverse drug reactions varying from transient maculopapular rash to fatal toxic epidermal necrolysis. Aims and the objectives of the study are to determine the prevalence of the cutaneous adverse drug reactions among the patients attending the tertiary care center, to study the clinical pattern of various cutaneous adverse drug reactions, to ascertain the various positive drugs responsible. The study was a hospital-based cross-sectional study conducted in a tertiary care center over a period of 12 months, that is from November 2020 to October 2021. Patients with cutaneous adverse drug reactions attending the dermatology OPD and inpatients of other departments formed the source of data. Patients who are not giving informed consents and patients with no prescription and patients using herbal medications formed the exclusion criteria. The overall incidence of cutaneous drug reactions during the period of the study was 0.17%. Out of total 124 patients, 66 were females, constituted 53%, and 58 were males, constituted 47%. Among them, most of them are in the age group of 21 to 30 years, followed by 31 to 40 years. Distribution of the various cutaneous adverse drug reactions. Most of the reactions are in the form of fixed drug eruption, forming 46%, followed by the maculopapular drug rash, which formed 14%, followed by the acneiform eruptions and urticaria, each of which formed 8%. Incidence of the acneiform eruptions has been significantly raised due to the use of the steroids for the COVID in the recent times. Other forms of cutaneous adverse drug reactions are drug-induced pigmentation, drug reaction with eosinophilia and systemic symptoms, erythema multiforme, exfoliative dermatitis, hand and foot syndrome, lichenoid eruption, phototoxic reaction, purpura, Stevens-Johnson syndrome with toxic epidermal necrolysis overlap, and toxic epidermal necrolysis. Out of total 124 cases, 15 patients had severe cutaneous adverse drug reactions in the form of DrSS, exfoliative dermatitis, SJS with TEN overlap, and toxic epidermal necrolysis. Among them, DrSS and SJS formed 27%, followed by the exfoliative dermatitis, which constituted 20%, followed by the SJS and the TEN overlap, which formed 13%, and TEN alone formed 13%. Duration between the drug intake and the onset of the adverse drug reaction. Reaction time was found to be 1 in 10 days in 81% of the patients. Reaction time of 1 day was common in cases of fixed drug eruption and urticaria, and it ranged from 2 weeks to 3 weeks in case of drug hypersensitivity syndrome, Stevens-Johnson syndrome, and toxic epidermal necrolysis. Reaction time of more than 3 months was also found in 1% of the patients. Drugs commonly involved in cutaneous adverse drug reactions. The commonest class of drugs causing cutaneous adverse drug reactions were antimicrobials. Among these antimicrobials, antibacterials were the commonest subclass involved. Non-steroidal anti-inflammatory drugs were the second commonest, followed by the anticonvulsants. Other groups were anti-tubercular drugs, anti-leprosy drugs, anti-malarials, and anti-cancer drugs. More number of cutaneous reactions were seen with fluoroquinolones, forming 20%, followed by the NSAIDs, which formed 15%, followed by anticonvulsants, penicillins, cephalosporins, and tetracyclines. Ofloxacin was the most common drug causing cutaneous adverse drug reactions. Second common drugs were methylprednisolone and ciprofloxacin with 9 cases. Maximum number of cases were seen with the patients taking the drugs for diarrhea. Out of total 124 patients, 28 cases had oral mucosal involvement, which formed 22%, and 4 patients had genital involvement, which constituted 3%, and 12 patients had both oral and genital mucosal involvement, which formed 9%. Recurrent episodes were seen in 19 patients of all the total cases, constituting 15%. Oral mucosal involvement was most commonly seen with NSAIDs, followed by metronidazole, phenytoin, norfloxacin, and ofloxacin in succession. First picture shows acneiform eruption on the face and the trunk region. Second picture shows erythema multiforme lesions on the palms. This is a picture showing exfoliative dermatitis. There is diffuse erythema and scaling over the trunk and the upper limbs. First picture shows fixed drug eruption. Second picture shows bullous fixed drug eruption. This fixed drug eruption heals with a slate gray pigmentation. This is a picture of hand and foot syndrome following the drug intake of sorafenib. This is a picture of toxic epidermal necrolysis after the drug intake of phenytoin. More than 30% of the body surface area is involved. Large sheets of the necrotic epidermis is separated. Conclusion. Knowledge of various clinical patterns of cutaneous drug reactions and causative drugs is important to the clinicians, which aids in early detection of the adverse event and helps in reducing the morbidity and mortality associated with it. These are my references. Thank you.